Hi, everybody, and welcome. My name is Rebecca Picasso, and I'm the Program Director for the California Telehealth Resource Center. Today, we're going to talk about telehealth reimbursement during COVID-19 for FQHCs and RHCs. So the first thing that I want to mention is that reimbursement information is constantly changing during the COVID-19 public health emergency. The information contained in this slide deck is current as of April 20th, 2020 at about 5 p.m. As a reminder, please check your local, state, and federal health plan pages for the most current and up-to-date information. So let's dive right into Medicare. Traditionally, Medicare telehealth services has 5 criteria for payment. So the patient has to be seen at an originating site as defined by CMS, and the originating site must be located in a rural area, again, as defined by CMS. Currently, during the COVID-19 public health emergency, those restrictions have been waived. So patients can be in their home, and they can be in an urban or a rural location at the time of the visit. Some additional restrictions that they had was that the encounter has to be performed at the distant site by an eligible practitioner, and RHCs and FQHCs could not provide services as a distant site for Medicare. That has been waived with the passage of the CARES Act. So for the duration of the public health emergency, FQHCs and RHCs can act as a distant site provider. The patient must be present and the encounter must involve interactive audio and video telecommunication. That is still effective and in play. The type of service provided must fall within the Medicare eligible services table. So CMS has a telehealth services fact sheet that they update once a year that has all of the normal telehealth codes that they will reimburse for. However, they've added an additional 80 codes to the existing list of eligible telehealth services. So the link that is down there in the purple box is the one that you should check, which will give you all almost 200 codes that are applicable right now. Just as a little reminder, FQHCs and RHCs typically bill for an originating site fee at Q3014. However, when the patients are at home, the originating site fee is not applicable. So the home does not qualify for an FQHC or an RHC, or any practitioner actually, to bill for a Q3014. So just keep that in mind. CMS has given you a mechanism to act as a distance site and bill your normal CPT or HCPCS codes, and you're going to want to do that instead of billing this Q3014. So what do we know right now? So on April 17th, CMS released an MLN which detailed payment information for FQHCs and RHCs during the public health emergency. So you guys will not be paid your PPS or air rate for telehealth services. Instead, you'll receive $92 per visit. And we're going to go into that a little bit more in depth here in just a moment. Distant site services can be furnished by any healthcare practitioner working for the clinic within their scope of practice. The provider does not have to physically be in the clinic. The provider can be working from home and you can still bill. You also do not need to update your home office with CMS or any other payer. It's perfectly fine that you just bill as if you were at the clinic. So let's go into some payment stuff here. So for claims January 27th through June 30th, 2020, clinics will be receiving their PPS or air rate. However, CMS will be reprocessing these claims in July and will be adjusting the payments back down to $92. So what does that mean? That means if a clinic's PPS or air rate is less than $92 a visit, Medicare will pay an amount equal to the number of telehealth visits the clinic conducted, multiplied by the difference between the PPS and the air rate and $92. So let's say that your air rate is $82. They're going to go ahead and pay you your air rate of $82, but then in July, they're going to take the number of telehealth claims that they paid you for, and they're going to multiply that by $10 because that's the difference between your $82 air rate or PPS rate and the $92 they should have paid you, and they're going to pay you the rest of that money. Now, if your PPS or air rate is more than $92 per visit, Medicare will recoup an amount equal to the number of telehealth visits that your clinic conducted during the time frame, multiplied by the difference between your PPS and air rate and $92. So let's look at that visually here. So let's say your PPS or air rate is $200, and between January 27th and June 30th, your clinic provided 450 telehealth visits. Your clinic was only entitled to $92 for each of those visits. So CMS is going to recoup roughly $38,880 from the clinic in July. So what does that mean? That's your $200 PPS rate or air rate, subtracting the $92 that they were actually supposed to pay you, which left a difference of $108. If you take that $108 and you multiply it by 450 encounters, you get a total of $48,600. Then you're going to multiply that by 80%, which is the amount that Part B is supposed to pay, because the other 20% is due by the patient, and that leaves you with $38,880. So all of this is just to make sure that you absolutely understand that while you will be receiving your PPS or air rate up until June 30th, understand that a recoupment will happen if your PPS or air rate is more than $92. If it is less than $92, then an additional payment will be coming to you when CMS reprocesses these claims in July. Reprocessing will happen automatically. There's nothing that you need to do to worry about those claims. They will automatically reprocess. So how do I bill for them? So what you're going to do is you're going to bill exactly how you would in person. So you're going to bill your normal CPT code or HCPCS code for an in-person visit for anything that occurred January 27th through June 30th, 2020. You have to append modifier 95 to the claim. And the POS that you're going to use is going to be equivalent to where the service would have been rendered in person. So again, normal CPT code, modifier 95, normal place of service code. Those are for claims January 27th through June 30th. Starting on July 1st through the end of the public health emergency, you're going to bill all of these telehealth claims with a different code. It's G2025. There will be no modifier necessary, and these will automatically pay at the $92. So why do you have to go through all of this, you might be wondering. So CMS typically updates their systems once to twice a year. And so they didn't want to make you guys wait to bill for services until July, when they could get their system updated with that G2025 and the correct payment rate. So what they did was they just basically turned on a modifier, and they said, go ahead and bill us. It's going to pay you your PPS rate. There's nothing we can do about that. And then we'll adjust the claims once this new code has been put in and our systems are updated. So they did it in an effort to try to get you paid as soon as possible. I don't know that they realized that the recoupment thing could be a big issue. So keep in mind that when you do get paid your PPS or your air rate for these visits through June 30th, you may want to put that money aside so that you're not taken aback when the recoupment comes, if it is going to come. The other thing to keep in mind is that right now the payment, right now and starting July 1, the payment is $92 through the end of the public health emergency. If the public health emergency is in effect after December 31st, 2020, the payment rate will be updated based on the 2021 physician fee schedule average rate for these services. So basically there may be an increase if the public health emergency continues after December 31st. So let's talk about some other payment abilities that you have. Retroactive to March 1st, CMS will pay 100% of the FQHC or RHC PPS or air rate, including for telehealth visits, for visits and services related to COVID-19 testing. So what that means is that instead of getting paid $92, if you're treating someone that is COVID-19, you will get paid your PPS or your air rate. For visits and services related to COVID-19, clinics must waive the collection of coinsurance for Medicare beneficiaries. So if the person is being treated or tested, you have to waive all coinsurance. But if they're just if they're being seen for normal everyday services, maybe they have a cold and it's not related to COVID-19, you have the option to waive cost sharing for all telehealth services. So just keep that in mind. For all visits and services in which the coinsurance is waived, RHCs and FQHCs must append modifier CS on the service line. So now, if you're doing this via telehealth, you're going to append modifier 95 and modifier CS. There will be two modifiers if it is a COVID-19 patient and the service is directly related to that. Claims with the CS modifier will initially be paid with the coinsurance applied. However, the MAC will automatically reprocess these claims beginning on July 1, 2020. And keep in mind that coinsurance should not be collected from the beneficiaries if the coinsurance is waived. So let's go into a little bit of a recap here. No restrictions on originating site or location of the patient at the time of the visit. FQHC or RHC provider does not need to be located at the clinic. They can be in their home, and they do not have to register their home office with Medicare during the emergency. The patient's home has been added as an eligible originating site. The patient can be located anywhere, not just in one of those rural areas as defined by CMS. The patient can present to any eligible healthcare site. They could present to a hospital or clinic, an RHC and FQHC, or they can be in their own home. And services cannot be audio only for traditional Medicare telehealth services. They have to be that interactive audio and video. So what else is available to you? Medicare has a bunch of different things that they call virtual visits. So let's talk about these a little bit and what those entail and how you bill for them. So the first one is virtual check-ins. Virtual check-ins are billed with code G0071. They are patient-initiated telephone or live video interactions. They must involve a physician or non-physician practitioner having at least a 5-minute check-in with the patient to assess whether or not the patient needs to come in for an office visit. The practitioner that is responding can respond to the patient's concern via phone, audio, video, telehealth, secure text messaging, email, or the use of the patient portal. So let's stop here really quick. So this one, if the patient calls you on the telephone and you respond to the patient on the telephone, that's perfectly acceptable in a virtual check-in. This is just about the only audio-only code that you'd be allowed to use. Please remember that these are patient-initiated. And while this slide does say check-in with an established patient, CMS is waiving that requirement during the COVID-19 public health emergency. So the patient does not have to be an established patient. Virtual check-ins must be for a condition that's not related to a service provided within the previous 7 days, and it doesn't lead to a service within the next 24 hours or soonest available appointment. There are no frequency limitations at this time, so you can use these as much as you need to. Keep in mind, though, that there's certain requirements on providers for these. So billable providers are physicians, nurse practitioners, certified nurse midwives, clinical psychologists, clinical social workers. If the discussion could be conducted by a nurse, a health educator, or other clinical personnel, it's not going to be billable as a virtual communication service. So these are more like triage, is kind of how I describe them. They're really for a patient to call or use live video or however they contact you and say, hey, I have a sinus infection. Should I come into the clinic? And you're going to say, nope, stay home. Going to order you some antibiotics, some Flonase, whatever it is that you're doing. And if they don't need to come in, they don't need to be seen, then you can bill for that. That's what a virtual check-in is. It is not meant to replace or act like a traditional telehealth service. For those billers out there, the place of service on this one is going to be equivalent to where the service would have been reported for an in-person visit. E-visits. E-visits are, again, a patient-initiated digital communication via an online portal that requires a clinical decision that otherwise typically would have been provided in the office. So e-visits are meant to be more like an in-person visit, but they're still done virtually through a patient portal. A billable provider must spend at least 5 minutes over the course of 7 days providing online E&M services. 7 days must lapse before you bill for this visit again. Now, here's the deal. E-visits are billed with code G0071, so very much like and actually the exact same code as the virtual check-ins. E-visits include multiple digital visits over the course of 7 days. If it's for relating to the signs or symptoms or conditions that are exactly the same. So what does that mean? That means that you can, if your patient calls you on Monday, if your patient initiates a digital communication through an online portal on Monday because they have pink eye, and you say, nope, you don't need to come in, just going to order you some stuff, go pick it up at your local pharmacy, and then stay home. And then on Friday, they contact you again and say, you know what, hey, my pink eye's getting better, I think it's doing good, and you verify and say, yeah, just keep finishing your course of antibiotics or whatever that is that they need to do. You can only bill for this e-visit once because they called you about the same condition or the same symptom within a 7-day period of time. Now, if they contact you on Monday for pink eye and on Friday they're contacting you for, some kind of infected cut on their finger, those are two different conditions and you can bill the G0071 twice. So just keep that in mind. So CMS took the CPT digital visit codes 99421, 22, and 23. They averaged out the payment for that, and that's the payment that they've created for these e-visits. Place of service, again, is equivalent to where the service would have been reported for an in-person visit. And the last one here is remote evaluation services, which is a store and forward type of service. So it's also billed with a G0071. And these are also patient initiated and consist of a practitioner evaluating a patient's transmitted information via pre-recorded video or image. Again, the practitioner can respond to the patient's concern by telephone, audio, video, secure text messaging, email, or the use of the patient portal. The service can only be billed if the condition is not related to a service provided within the previous 7 days and doesn't lead to a service within the following 24 hours or soonest available appointment. There, again, are no frequency limitations, and you still have the same restrictions with billable clinicians. So it has to be a physician, NP, PA, CNW, clinical psychologist, and clinical social worker. If the discussion could be conducted by a nurse or a health educator or any other clinical personnel, it's not going to be billable as a virtual communication service. So how do you bill the G0071? You're going to use your normal UB04 claim form. Your type of bill for your RHC is 711, for an FQHC it's 771. Your revenue code should be 0521. No modifiers for these. So for the G0071, no modifier needed. Again, place of service code is going to be exactly like it would be for in-person visits. And for the public health emergency period and effective March 1, CMS is going to pay $24.76 for these. So that's that averaging out of those 3 CPT codes I talked about a moment ago with the e-visits. And because normally outside of the public health emergency, these payments are around $14. Let's talk about consent real quick. So a verbal patient consent is required for all virtual visits. That's the virtual check-ins, the e-visits, and the remote evaluation. Consent can be obtained at the time that the service is furnished or prior to the service being furnished during the emergency period. And consent can be obtained by ancillary staff under the general supervision of the RHC or FQHC provider. So it doesn't necessarily have to be the provider obtaining consent at all. Just a quick note about video platforms. This is something that is significantly different than normal. So right now, the Office of Civil Rights has temporarily relaxed its enforcement standards during the public health emergency to allow healthcare providers to use video technologies that do not fully comply with HIPAA rules and regulations. These include non-public facing video products such as Skype, FaceTime, things like that. However, keep in mind that if you're choosing to use a product that is not HIPAA compliant, you are required to obtain a separate consent from the patient that they've been notified that there may be additional privacy risks and things that they need to look out for, and that you're using a non-HIPAA compliant platform. That said, it takes just as much time to use a HIPAA compliant platform as it takes to use a non-HIPAA compliant platform. So wherever possible, we always encourage providers to use a HIPAA compliant platform. So where can you go if you need resources and help? So CMS has their current emergencies page. That lists all the waivers, a lot of their MLNs, and things like that. They're all on that current emergencies page. They also have the CMS newsroom, which lists all their articles and media, public-facing media, press releases and things that they put out. And then there's the MLN Connects newsletters. So that box there at the bottom of your screen where it says receive email updates, if you were to click on the link for the MLN Connects newsletter in these slides, at the very bottom of that page, you're going to see this box. Just type in your email, hit submit, and you'll start receiving those MLN Connects newsletters. They're super, super helpful. So let's talk about Medi-Cal. Medi-Cal has come out with their new guidance. FQHCs and RHCs are able to bill their PPS or air rate as applicable for live video telehealth and telephone services. Traditionally, for Medi-Cal, patients had to be HHMS, which means homeless, homebound, migratory, or seasonal workers, in order for an FQHC to provide services to them in their home. Right now, during the public health emergency, patients do not have to be HHMS to be seen in their home. So below is a chart that kind of outlines the HCPC or CPT codes for billing either Medi-Cal fee-for-service rate or your PPS rate. So what you're going to do is you're going to put your applicable revenue code plus a HCPC code. So if you're billing fee-for-service Medi-Cal, that HCPC code is going to be T1015. If you're billing managed care, it's going to be T1015SE. And then you're going to add your CPT code. So either a 99201 to 205 or a 99211 to 215. No modifiers are necessary. Place of service code is going to be exactly as it was in person, all that good stuff. Now, here's the thing that this chart doesn't exactly tell you. If you're billing for behavioral health, your CPT code is going to be 99201 to 99205 for new patients, 99211 to 99215 for an established patient, and you're going to need to put your behavioral health CPT code as well. So for mental health, you're going to have 2 CPT codes on that claim in the informational lines. So that's for billing your PPS or air rate. If you're not going to be billing your PPS or your air rate, you can bill the G0071 for those virtual communications as well. So this is, again, is just kind of a reiteration of what we just talked about, that how you list your HCPC code, your CPT codes, all that good stuff. Please note that the CPT codes are not necessarily separately reimbursed, but instead are used to identify the virtual and telephonic communication, as well as being used by DHCS for tracking and reporting purposes related to COVID-19. If you're going to be billing the HCPC code G0071, you should only list the HCPC code on the payable claim line and should not include a corresponding CPT code. For your Medi-Cal managed care plans, you will receive your PPS or error rate as applicable for rendering a covered benefit or service, whether it was provided through telephone or virtual telephonic communication, as long as you meet all the criteria. And DHCS will ensure that you guys are made whole with an appropriate RAT payment consistent with existing DHCS policies. So they just want you to know that you will get your RAT for these. DHCS has kind of a helpful little FAQ in their telehealth and other virtual telephonic communications fact sheet. So I thought I would include some of these here because I feel like there's stuff that we don't necessarily think about all the time. So can physicians and healthcare practitioners in an FQ or an RHC provide covered services via virtual telephonic communications and receive the Medi-Cal fee-for-service rates for the G0071? The answer is yes. Are registered nurses or licensed vocational nurses able to provide Medi-Cal covered services via virtual or telephonic communication? The answer is no. Medi-Cal has not changed its policies on billable providers and practitioners, and RNs and LVNs are not considered a billable practitioner. Do FQs and RHCs bill covered services provided via virtual telephonic communication the same way as if it was in person? The answer is yes. Providers will submit claims using the applicable revenue code, HCPC T1015 or T1015SE, and the appropriate CPT code for reimbursement at the PPS rate. Keep in mind that along with that CPT code for new patient or follow-up patient, if it's behavioral health, you need a second CPT code. And then if you are participating in any specialty mental health services, for example, those contracted with county mental health plans or the drug Medi-Cal system, they've put out a behavioral health informational notice and an FAQ where you can find some more information specific to those programs. So let's talk about consent for Medi-Cal real quick. Typically, in the state of California, healthcare providers must inform the patient about the use of telehealth and obtain verbal or written consent from the patient for telehealth being used as an acceptable mode of delivering healthcare services. That has been waived. Governor Newsom put out an executive order N4320 on April 3rd, which removed the consent requirement during the public health emergency. I'm getting a lot of questions from providers that still want consent. You absolutely can get consent. You can get that orally, you can get that in writing, you can get that however you'd like to get that, but you're not required to get that for Medi-Cal through the remainder of the public health emergency. Documentation, we get a lot of questions on how do I document this? Your documentation should be exactly as it would be for in-person services. So you just need to make sure that you maintain the appropriate documentation to substantiate the CPT code or HCPC that you're going to bill. You do want to document that these services happened via live video or via telephone. But otherwise, your documentation should be exactly the same for in-person as it is for telehealth or telephone. Medi-Cal has some pretty cool resources set up. So if you have questions about Medi-Cal's telehealth policies, you can email that email address up there and get a response relatively quickly. The California Department of Healthcare Services also has a telehealth webpage, and they have a COVID-19 resource page as well. So does the Department of Managed Healthcare. So the COVID-19 resource pages for both the HCS and DMHC are kind of my go-tos right now. That's where I'm finding a lot of helpful and useful information. CTRC also maintains a telehealth reimbursement guide for the state of California that covers Medi-Cal, Medicare, and some of the private payers. However, this reimbursement guide is not being updated for COVID-19. It would be almost impossible to keep it updated. So what we've done is on our reimbursement page, right underneath where you would normally download the reimbursement guide, we've included COVID-19 reimbursement updates for CMS, DHCS, and also managed care and commercial payers. So you could, if you wanted to, you could go to our website and check out some of these resources. You are also welcome to call or email us and ask your questions as well. Let's just touch on private payers and managed care real quick. So all health plans right now should be reimbursing for telehealth and telephone during the public health emergency. The reimbursement rate should be equal to the same rate as it would be for in-person services. Modifiers could be different. Some plans are using 95 and some are still using the GT modifier. Place of service could be 02, or they could ask you to use your normal place of service. The bottom line is, guys, listen to your health plans, even if they want you to bill in a way that you are not used to. Bill however they tell you to bill. Get paid. So DMHC put out an APL on March 18th that directed the health plans to reimburse for telehealth and telephone at the same rates that they normally would. As a follow-up to that, DMHC put out another APL on April 7th. And I'm not going to read everything here, but that last little paragraph is super important. So the department had heard from providers and enrollees that health plans were requiring their members to access services through the plan's contracted telehealth vendors like Teladoc or MDLive, rather than covering telehealth services delivered by contracted providers who would typically deliver the services to their members in person. So during COVID-19, the public health emergency, a health plan may not require members to use the plan's telehealth vendor or a different provider from the one that they typically see if the member's provider is willing to deliver the service to the member via telehealth and the member consents to receiving services via telehealth. So what does that mean? That means that the health plan cannot say, you, FQHC provider, are not eligible for telehealth even though your patient wants to use it because we use Teladoc. They can't do that anymore. Now they have to reimburse you for telehealth services as long as your member, your patient consents to the telehealth service and as long as you are willing to deliver that service. So that said, that's the end of our presentation. If you have any questions, please feel free to reach out and give us a call, shoot us an email, use the contact us form on our website. We're happy to help as much as we can. Thank you so much, and I hope you all have a great day.